Hello, everybody. Welcome to this community talk on burden and diagnosis of vaginal and sexually transmitted infections in pregnancy in Addis Ababa, Ethiopia. The speaker of today is Professor Piet by Ghent University. Before we give him the floor, I just have a couple of practical announcements. Firstly, if you have any questions throughout the presentation, feel free to submit your questions in the chat. We will make sure to address them during the Q&A after the presentation. Secondly, please keep your microphone muted during the presentation, but during the Q&A, you are welcome to unmute yourself, turn on your video, and to ask your question directly. And lastly, please be aware that this community talk is recorded and we will share it afterwards on our YouTube channel. So with these practical announcements done, we can now go to the community talk. We really hope you will enjoy it. And I give the word to Professor Piet.
Okay, thank you very much for the introduction and also to invite me for this community talk. As said, I will talk about the burden and the diagnosis of vaginal infections and sexually transmitted infections in pregnant women from Ethiopia. Let me start with some background. If my pointer is here. So why are sexually transmitted infections, why should they be a global priority? Well, on a yearly basis, there are almost 400 million new cases of the four curable STIs, so sexually transmitted infections per year. These are strongly linked with fetal and neonatal mortality. They are the cause of cervical cancer, some of them, namely HPV. They are linked or causing infertility, and they increase the risk for HIV. So besides these sexually transmitted infections, the burden that they also cause, they also have a very important impact on the quality of life, of course. Now, a healthy vaginal microbiome is equally important than the burden of all these STIs because a healthy microbiome protects against all these STIs. A healthy vaginal microbiome ensures a healthy pregnancy, and a disturbance of a healthy microbiome, which we call a dysbiosis, is associated with adverse pregnancy outcomes. And also the dysbiosis is causing symptoms which affect the quality of life. And dysbiosis affects up to 1 in 3 women globally. So let's have a closer look at the vaginal microbiome and the diseases it can cause, namely vaginitis. Here on the left-hand side, we see a representation of what we call a healthy vaginal microbiome. This microbiome is dominated by lactobacilli, mainly Lactobacillus crispatus, and we see here a thick mucus layer which is protecting against pathogens like HIV, HPV, and is dominated by these rods, which we call lactobacilli. Here you see a picture of that under the microscope, epithelial cells and many lactobacilli. When the system is disturbed, we call it bacterial vaginosis. We see that these lactobacilli disappear and others start dominating the niche, namely pathogens like Gardnerella, Neisseria, Prevotella. And they form what we call a biofilm. So they start colonizing and attaching to these epithelial cells, which we call clue cells. And here you see a picture of that, which is totally different from this epithelial cell. So it's really a biofilm on top of the epithelial cell. What is very important in this niche is the low pH. So these lactobacilli, they acidify glycogen and they acidify by that the vagina to very low pHs around 3.5 to 4, which is protecting against pathogens. On top of the system, besides bacteria, we can also find yeast, namely Candida, mostly Candida albicans, and we find this yeast in both the healthy vaginal microbiome as well as the disturbed vaginal microbiome. And it's important to realize that both these disturbed conditions can lead to symptoms, but it can also remain asymptomatic, and also the yeasts, they can cause symptoms or they can be present without causing harm. So we call that an asymptomatic candidiasis. Now, a key player in that system is Lactobacillus crispatus. It's a very important bacterium which is able, with his superpower 1, to acidify the vaginal niche by the production of lactic acids. So it really lowers the pH, but it also produces antimicrobial peptides which attack pathogens that maybe enter the vagina. And as a superpower 3, it also produces hydrogen peroxide, which is also protecting against pathogens in the vaginal niche. So Lactobacillus crispatus is able to dominate the vaginal niche as a single species, which is really unique, not only in humans, but also in other animals, that we have a single niche dominated by a single species. Now, on the other hand, those pathogens of the dysbiosis, like Gardnerella, they are comprised of different species, and some of them have virulence characteristics such as sialidase. And sialidase, it's an enzyme that is able to break down the protective mucus layer covering the vaginal epithelium. So here we see Gardnerella breaking down the mucus, and when this mucus layer is broken down, we open the gateway for pathogens to enter the vaginal epithelium, and also the broken down mucus is causing then vaginal discharge. Here we see some more images of the vaginal microbiome, with here in A on the top left, a healthy vaginal epithelial cell. And here we see some candida cells and some hyphae. And here we see clearly two examples of clue cells, so vaginal epithelial cells covered in biofilm. That vaginal niche, so the vaginal microbiome, can be very, very dynamic. There are many factors that disturb it, and one of the main disturbance factors is the menstrual cycle. So this seems like a very complex figure, but actually what it represents is the composition of the vaginal microbiome on a daily basis for one woman. So if we look at one of those rectangles, it represents the microbial profile. And for instance, this here in the middle, you see that that woman has a vaginal microbiome dominated by Lactobacillus crispatus for a week. And then after the end of the menses, the vaginal microbiome changes almost overnight to a microbiome dominated by another species, namely Streptococcus agalactiae. And then after some time, it restores, and then we get another lactobacillus that dominates. So this is really a very dynamic microbiome. Important to realize, and I'm not going to discuss the whole figure, but just remember that we have the microbiome on top. So this is the first line of defense, the bacteria. But below that, we have a whole immune system, the vaginal immune system, which is composed of a cellular component. So we have different cells that aid us in protecting against pathogens, but we also have antibodies that are below the vaginal microbiome. And a disturbance of that microbiome is associated with subclinical inflammation. That means even if the lactobacilli disappear and some others take over, it will not cause an inflammation, otherwise we would call it vaginitis. But it's still associated with immune markers that we consider as an inflammatory response. And that has important consequences, because it may be that women with bacterial vaginosis are asymptomatically, but their immune system has a signature of inflammation. And inflammation, if that happen for a long time, is associated with cancer progress and also with recruitment of, for instance, HIV. So HIV targets some inflammatory cells, and if they are present because of a disturbed microbiome, we increase the risk for HIV. It's also important to realize that this vaginal microbiome is in constant communication with other microbiomes. This is one example depicted here. So here we have the vaginal microbiome. It's in constant direct communication with, for instance, the urinary bladder microbiome, but also with the gut microbiome. And these are direct communicating vessels, but there are also indirect associations between these microbiomes. And as an example, I give you this one. So again, this seems like a complex figure, but what I want to show here is that we have here the vaginal microbiome with, for instance, lactobacillus. And here we have the gut microbiome with many other bacteria, and they can communicate directly, but also indirectly. And one example is that the microbiota of the gut is able to process some molecules, for instance, estrogen-like molecules. And those estrogen-like molecules are then transported through the circulation and end up in the vaginal microbiome where they stimulate lactobacilli. So there's an indirect and both a direct interaction between the vaginal microbiome and other microbiomes. Now let's skip a bit from the microbiome to the clinical and the public health implications and ask ourselves the question, globally, where do newborn babies die? And it will become clear why I asked this question. So globally, most babies die in sub-Saharan Africa. Here we see the top 10 countries with the highest number of neonatal deaths, and we see that Ethiopia is on number 6. And when we look at the highest rates of neonatal mortality, these are almost all African countries. Now, what are the global causes of neonatal death? We actually have 3 main causes. And the first, number 1, is preterm birth. So babies born too soon, especially in resource-poor countries, they have less chance of survival, and it's still globally the number 1 cause of neonatal death. Number 2 is intrapartum complications, like the shortage of oxygen. And number 3 is neonatal sepsis. And there's a very important link. The vaginal microbiome has a very important influence on preterm birth and neonatal sepsis. So let's start with preterm birth. This is a summary of all studies that investigated the link between a healthy microbiome and a disturbed microbiome, namely BV, and preterm birth. And we see that very consistently, almost studies show that if women have BV, the odds for preterm birth is increased. It's important that it's not only symptomatic infections that increase the risk for preterm birth, but also in asymptomatic infections. For instance, in Congo, we showed that if women have asymptomatic dysbiosis or asymptomatic carriership of Candida, it also increases the risk for preterm birth and low birth weights. Now, preterm labor, which is preceding preterm birth, is multifactorial, but has a very important infectious component, mainly the disturbed vaginal microbiome. If we then look at the study that did amniocentesis, so they sampled women in preterm labor which had an intrauterine infection, then we see that the microbes recovered from that amniotic fluid are indeed the ones that we expect in a vaginal dysbiosis. For instance, here, Gardnerella vaginalis, but also some ureaplasmas. So this is consistent. This is extra evidence showing the link between dysbiosis and preterm birth. I told you number 3 cause of death globally is neonatal sepsis, and this has also a very important link with the microbiome, because neonatal sepsis is a blood infection of the neonates, and the pathogens infecting those neonates, they originate from the vagina. So when the fetus is born and passes through the vaginal channel, some bacteria, mainly group A streptococci, they are transmitted towards the neonates, or the neonate can inhale it, and then GBS passes to the alveoli and then enters the bloodstream and causing this neonatal sepsis or these bloodstream infections. So another way where the microbiome is contributing to high neonatal mortality rates. So we can safely conclude here that mom's microbiome really matters for the reasons I just explained. But there's more to that. Mom's microbiome also matters for other reasons. And one important aspect is the following. In the womb, so in the uterus, a fetus is sterile, but is colonized when it passes through the vagina. So the first bacteria the neonate meets in his life or her life are the ones that are present in the vaginal microbiome. So if that microbiome is disturbed, the neonate receives a totally different microbiome, and this has important health consequences. So it has been shown that disturbing factors like C-section or perinatal antibiotics or formula feeding, these are all factors which make that a neonate doesn't get the right bacteria because in C-section, a baby is taken out of the womb and doesn't see the vaginal bacteria. And perinatal antibiotics, the microbiome, the vaginal microbiome is disturbed, and also the baby doesn't meet the right bacteria during birth. And also in formula feeding, the baby doesn't receive the good bacteria from the mother milk. So mom's microbiome has a very, very important role in neonatal and child health. Just one example, here is a study showing the difference between vaginal delivery and a C-section. And here we see the baby sampled after 4 days, and we see that most of the bacteria of the neonatal gut are actually the ones that we expect in the vaginal microbiome. But when baby is born by C-section, we see a totally different microbial fingerprint of that neonate, and we more see environmental bacteria. So enough about the microbiome. Let's discuss a bit the true sexually transmitted infections, the STIs, and one of the most important one is HPV. Is a causative agent of cervical cancer, which is one of the most preventable but also prevalent types of cancer. A few years ago, about 600,000 women were diagnosed with cervical cancer globally, of which 350,000 died from that disease. And as said, human papillomavirus is the single cause of cervical cancer. The key pillars to prevent are quite easy. They are vaccination and screening. Very briefly, the pathogenesis starts when the normal cervix is infected by HPV, but it's important that the productive infection can easily be self-cleared. So not all women who are HIV positive remain positive, and there's a dynamic interaction between clearance and infection. Even if the infection remains, the progression into the pre-cancer lesions, which we call SIN1, SIN2, and SIN3, they can still regress. It's only in the latest stage when there's progression into invasive cancer that there's no way back. Now there are many different HPV types, which you see here listed, but there are only a few ones that are what we considered high risk for cervical cancer, or HR HPV. And the most prevalent ones are here at the right. We have HPV 16, 18, 31, and so on. So these are the most prevalent high-risk HPV genotypes. As said, one of the key cornerstones to prevent cervical cancer is, since 2009, HPV vaccination. And WHO has pre-qualified 5 vaccines, which you see listed here. And in Ethiopia, since 2018, the Gardasil 4, which you see listed here, has been implemented, and the target groups are school girls aged 14 years. So that Gardasil vaccine has 4 genotypes covered, namely genotype 6, 11, 16, and 18. Here's some data on the coverage and some extra epidemiological data. So in Ethiopia, cervical cancer is actually the second most common cancer, with an estimated annual new cases and deaths of about 4,000 and 5,000 respectively. And here we see that coverage is going well. A few years ago, 2000, at the beginning of the 2020s, 1 in 3 target women were vaccinated, which fits in the global trends of vaccination, which you see here. So this is from 2006. And when we look at the progress, oh, this goes a bit fast. I'm sorry for that. We see that more and more countries are reaching the target of the entire country being vaccinated. Now, regarding screening, there are 3 main ways to screen women. The first one is cytology, and cytology takes a clinical sample and investigates the different epithelial cells under the microscope, and actually tries to find cells that don't look normal. So they screen for atypical cervical cells. So this cytology method is actually providing a status of the current cervix. Then there's also HPV testing using molecular diagnostics, and that strategy aims to detect HPV. So the strategy there is actually to predict what is going to happen. If you have a consistent infection with HPV-16, you will develop the different stages. So that's looking into the future. And what's mostly used in African or low resource settings is VIA, and that's a visual inspection of the cervix after adding acetic acid. And if you add acetic acid to the cervix, those malformous lesions will pop up as being white. So that's an easy and cheap, feasible way to screen for HPV. Here you see an overview. You see that in more industrialized countries, there's now the overlap between HPV testing by PCR and cytology. But it is rapidly changing. For instance, in Belgium, we now only screen with HPV. But you see in many African countries, there's no official recommendation, and still the pillar of screening is based on that visual inspection of the cervix. What is important that HPV for screening is that self-sampling is becoming more and more important. A lot of research has been done on that because we know from other studies that, or from other infections, that it's a well accepted way of sampling. And especially in some settings, it increases the uptake of screening and it increases the coverage. Also, sometimes it reduces access barriers and it aids us in to reach hard to reach populations. So another important infection is trichomoniasis. It's caused by the protozoan Trichomonas vaginalis, which you see here. So it has a flagella and is able to swim around the epithelial cells. It's very curable. There's no resistance almost, but it's also associated with preterm birth, low birth weight, also with infertility and even with cervical cancer. So trichomoniasis is a highly prevalent STI, though very curable. Another one that we focused on in our study is chlamydia. Chlamydia is a STI caused by the bacterium Chlamydia trachomatis. It's highly associated with pelvic inflammatory disease. It's causing a high rate of infertility in women if not treated. It's also linked with pregnancy, adverse pregnancy outcomes, and also importantly with neonatal complications if left untreated. A few examples are lung infections by Chlamydia trachomatis or eye infections leading to blindness in neonates. And then last STI I want to introduce because we researched it in our setting is Neisseria gonorrhoeae, which is a bacterium which is still curable, but resistance is highly emerging. It's also causing or associated with preterm birth, low birth weight, causing infertility and linked with cervical cancer. So now that we know all these STIs and the microbiome and the disturbances of the microbiome, the ideas I want to discuss here is how are these infections managed in African settings like Ethiopia. And one very important idea and introduction by WHO was the syndromic management. It has been around for almost 3 decades. And what is syndromic management? So introduced in 2003. It's used of standardized flowcharts for all STIs, so including bacterial vaginosis and candida. And the entire management is based on the presence of symptoms and easily recognizable signs because there's no lab testing available in most settings. And they use different syndromes, and one of the main ones for genital tract infections is a vaginal discharge syndrome because vaginal discharge is a common symptom for many of the infections and disturbances that I just discussed. But the consequences, if a patient comes with vaginal discharge, very bluntly said, clinicians are suggested to treat for whatever that syndrome, for whatever pathogen can cause that symptom. For instance, for vaginal discharge, it's recommended to treat for BV as well as trichomoniasis as well as candida if women are symptomatic. And those are 3 different conditions, so meaning that 3 different treatments are given. On top of that, if there's a risk that woman also has chlamydia or Neisseria, there's an extra treatment recommended for those infections also. But this way of managing women in antenatal care, it has an important consequence, namely not all women are diagnosed even if they have an STI. So only those women with symptoms are treated or detected for STIs, while most of them actually remain asymptomatic and giving the syndromic treatment, they will never be treated. Yet, those women with an STI that is asymptomatically are also at risk of all the health implications for the neonate I just listed. So this is what an ideal management should look like. If you have a patient, there should be a clinical evaluation, diagnostic leading to diagnostics. And those diagnostics, they then steer the antimicrobial treatment. But when we talk about syndromic management, this is actually the system that is being used, namely from patient to treatment. There's no diagnostics to steer the treatment. And this has, of course, important consequences. And one of the most important one is antibiotic resistance. There are projections that by 2050, resistance will cause more deaths than cancer. And one of the contributing factors are these syndromic management strategies. So if we treat STIs, BV, and Candida, empirically, this highly contributes to resistance emerging in those countries. It's also important to realize that the main symptom, discharge, it's very difficult for women and even for clinicians to make an interpretation. So you have all kinds of discharge, and here you have 2 studies that clearly show that women or clinicians are sometimes very bad at interpreting the cause of the discharge. So even if the discharge is healthy, clearly and watery, it's misinterpreted by women as well as by clinicians sometimes. So important to realize that globally, in all settings, women cannot pinpoint the cause of their vaginal symptoms themselves. It's also important to realize barriers that vaginal symptoms carry a heavy psychosocial burden, of stigma, shame, and fear of being judged as promiscuous. And this is, of course, an important barrier for women to also seek help. There's also a lot of self-treatment, also in African settings. For instance, this study in Uganda showed that many women use over-the-counter antifungals if they think they have a vaginal infection. But the self-diagnosis is often incorrect. Sometimes they have bacterial vaginosis and they self-treat for Candida and vice versa. So this is an important driver also of resistance. This is one study from Ethiopia, and they also showed that in that study, a lot of women, about 40%, reported self-medication. Many women mistreated themselves, thinking they had Candida and treated for BV and vice versa. So the message here that also in Ethiopia, self-medication among pregnant women is quite prevalent. There are tests on the market to help women in diagnosing their symptoms, like the BV Blue, but sometimes they are poor in sensitivity, like the study showing here, only maximum sensitivity of 50%. Also for Candida, there are self-tests on the market. Here we compared 4 of them, but we concluded the same, that most of them had a very poor sensitivity. So that questions the clinical utility of these point-of-care tests. Now, this brings me to the study we did, which was named the IMPRESS study in Addis Ababa, which was a VLIR-sponsored study. And because of the lack of good molecular tools, there's also a lack of epidemiological data of all these infections. So the first goal of us was to describe the epidemiology of all these reproductive tract infections in pregnant women from Addis Ababa in Ethiopia. And second goal was to have a diagnostic evaluation of different specimen types, like self-sampling and urine, for the detection of urinary tract infections. So we compared vaginal swabs with self-swabs and urine. And the third goal was the development and clinical validation of point-of-care tests for STIs. So what we did a cross-sectional study in Addis in an antenatal care setting. We recruited about 500 pregnant women, questioned about sociodemographics, vaginal symptoms, and did clinical sample collection and lab analysis. So for the STI detection, we used the C-gene test kits. So basically, we load the sample on a DNA extraction machine, and then we use several kits from C-gene for pathogen detection by means of qPCR. And these are the assays we used. We used 4 assays, namely the vaginitis kit, the HPV kit, the genital ulcer kit, and the sexually transmitted infections kit. And here you see all the markers that are present in all of these kits. We also aimed to develop and field test some point-of-care tests targeting Trichomonas. So one molecular tests, we try to give a proof of concept for that, and we also did a clinical evaluation for a serological test for Trichomonas vaginalis. Now, what I'm going to present are preliminary data. We're only started. The first analysis about a few weeks ago. But I can already describe the study population. So our study population was mostly urban. So about almost all women were urban. We had a mixed religion. About 50% were Muslim, 50% Christians. Mostly women were married. The sexual and obstetric history. We recruited women during their first antenatal care visit, but for most women, that was the 3rd trimester. And the median age was about 20 years. So regarding vulvovaginal practices, many women practiced regular vaginal douching, which is a huge risk factor for vaginal dysbiosis, using water only. And pit latrines were the main toilet type. And then the clinical signs and symptoms, as expected, the most prevalent clinical sign and symptom was vaginal discharge, about 25%, followed by vaginal itching and lower abdominal pain. Now let's have a look at the preliminary data on the prevalences assessed on the vaginal swabs. And this is a summary. I should not be here. Let me. Okay, anyway. So the most prevalent conditions were Candida albicans, about 1 in 4 women, bacterial vaginosis, and HPV. And then group B streptococci, about 10%. The Chlamydia, Trichomonas, and Neisseria were only present at very low prevalences. When we compare this data to global trends, we see that for Candida albicans, in our study it was 24%. The non-albicans were 6%. So when we added up, Candida was present at 30%, which is as expected. So this review describes 32% and 35% in East Africa. For BV, we were a bit lower than what was maybe expected. So during the last 20 years in sub-Saharan Africa, the prevalence of BV, both symptomatic and asymptomatic, is about 25%. And for TB, there are very few data. There's only one review, but it's in men and women and not limited to pregnancy populations. But for Africa, they report 12%, while we had a very, very low number of TB, namely below 1%. So as said, we had 6% of non-albicans Candida species, which is important that we have this resolution in Candida speciation because 50% of Candida glabrata has a decreased sensitivity to the first choice of treatment, fluconazole. And also global trends show that Candida glabrata is the second most common Candida. Another important one is Candida krusei, and that is fully resistant to fluconazole. And also global trends confirm what we found, that non-algal species are having a substantial part of the yeast infections being present in those populations. So for Hono, we had quite an unexpected low prevalence of 0.2%. If we compare that with a systematic review in pregnant women, we see that for the African region, the prevalence is much higher, namely almost 4%. And here in Ethiopia, in pregnant women, it's about 4% also. So in our study population, we were way below that. And the same is true for chlamydia. We only had 1% of women being positive for chlamydia, which is lower than estimates from systematic review meta-analysis. Namely, in women, it was about 7% for Africa, about 9% for Eastern Africa. So we were way below that in our study population. And these are results of our genotype distribution. We found 52 being the most prevalent one, followed by 16, 39, and 68. And together with 51, that made up almost 60% of our genotypes on HPV. This is somehow in line with what is known globally or in Africa. So we found a global prevalence of 14%, which is lower than what's reported here, 35, but that review also included low-risk genotypes. When we look at what we found in IMPRESS, 52 and 16 being most prevalent one, that is what is also being found in systematic reviews, so 52 and 16 being the most prevalent one. We did not find 18 to be important. Also for 53, we did not find that to be very important. 39, 68, and 51 were more prevalent in our population. When we look at HPV stratified by age, we also see a trend as expected, namely more prevalent in younger women than decreasing and rising up when women are above or reaching their 40s. And regarding the HPV genotype distribution, when we have the different vaccines listed here, the ones with a full circle are the genotypes covered. And this is the vaccine being used in Ethiopia, namely Gardasil 4. And when we look at the coverage that would give by in our study population, we see that actually 12% of women which would be covered by that Gardasil 4 vaccine. We also found that bacterial vaginosis is a risk factor for both HPV and Trichomonas vaginalis. So here we see the different infections stratified by a normal vaginal microbiome, by an intermediate one, or by BV. And we see that for HPV, for instance, the prevalence is much lower when women have no normal microbiome compared to a disturbed one. And the same is true for other infections like Mycoplasma genitalium, Mycoplasma hominis, and so on. Here there's a summary of the ones that are statistically significant. So Mycoplasma hominis, highly related with BV, Ureaplasma urealyticum also, but also more importantly, HPV and Trichomonas vaginalis. Regarding the point of care tests that was developed, this is in essence what we did. So the first thing we do is we heat the sample, and then there's a PCR-like reaction taking place at room temperature. And then the readout is using a plastic point of care device with a technique called NALF. So we did not do the clinical validation, but we showed a proof of concept using samples collected in the IMPRESS study. Here we see a lab-based evaluation, and here we have a dilution series of Trichomonas vaginalis, and we see that we detect here in the test line the protozoan until the sample gets too diluted. And here there's a clinical validation using a limited number of samples, but the positive ones using the C gene are also picked up by the point of care Trichomonas test. And so for the point of care serological test for TB, we evaluated this serological test which is on the market, but because we had too few cases of Trichomonas vaginalis, we could not assess the clinical sensitivity. We could do a cross reaction validation, and we did not find any false positives. So we could say it's a very specific test, but for now we will need to use other resources to assess the true clinical sensitivity. So then a few last slides on the sample types. The first for urine, I just give you the example for HPV. Here we see the analytical values of HPV in urine. So the higher the value, the lower the concentration, with 45 being negative. And we see that a lot of urines have HPV that are being detected in the paired vaginal swab, but not in urine. But also vice versa, urine is detecting some HPV which is not being detected. But overall, the sensitivity of urine is lower than the gold standard sample, namely the vaginal swab. And this is a trend we see for all infections. Urine has a suboptimal sensitivity, though the specificity is very high, almost 100% for all. We do see suboptimal sensitivity, except for Trichomonas vaginalis, which is being detected in all urine samples as we detect in the vaginal swabs. For self-sampling, the story is totally different. I just give you two examples for Gardnerella and Atopobium. And we see that almost all pathogens being detected in urine are equally detected in the vaginal swab at the same concentration, which translates into very high sensitivities of self-swabs versus normal clinician-taken swabs, and also very high specificities. So with that, I would like to thank you for the attention, and I'm also would like to thank our collaborators. First, I would like to thank Dr. Abella Berra, who was the PI of this study at Agri and Addis. I would like to especially thank also Miss Maria Solomon, who is a PhD student who did all of the lab work in Addis, the clinical sample collection, and so on. She has been the driving force of this study. I would also like to thank members of my own team, Lisa Hemschot, Natalia van Biesen, for their contribution for the molecular analysis. Our collaborators for the point of care testing are Chiara O'Sullivan, Christine Justo, and Vasso. And I would also like to thank Professor Alderete for his contributions to this project and our sponsors, Sigin, Clear EOS, and Accuramed for their contributions. Looking forward to your questions.
I would also thank you, Piet Coles, for the very interesting explanation. And I think you made it very clear and calm, even for someone like me who doesn't know much about the subject. So thank you for that. We already have one question in the chat, and I will ask it soon. If there's any other questions, please either put them in the chat or put your hand in the air and activate your microphone so we can have a real question. So the first question is from Amina Yusuf. She's asking how BV is a risk factor for HPV and TV as well for cervical cancer.
Yeah, well, thank you, Amina, sorry, for your question. So let me break it down. How is BV a risk factor for HPV? Well, if I go back to the first slide I showed you on the vaginal microbiome, if you have a disturbance of that microbiome, you have several factors at play. Namely, you don't have a very low pH anymore. And a low pH is really protecting women against many viruses. So many viruses like HPV, they cannot thrive into a low pH and they are being destroyed. So if you have BV, the pH increases to high pHs like 7 or even 8, and then you don't have that first line of protection anymore. A second explanation regarding HPV is that in BV, you don't have that thick mucus layer. So the BV bacteria, they eat away, let's say, the mucus, and the gateway are open for viruses like HPV and HIV to enter the vaginal epithelial cells or the cervical cells. There are many other factors, but those are two important ones. And then you can apply the same reasoning for other pathogens like TB. If you don't have a first line of protection, those principles I just explained do not only apply for HPV, but also for other pathogens like TB. And of course, if you have more HPV, which is a causative agent of cervical cancer, a disturbed microbiome is also associated with cervical cancer. So I hope that addresses your question, Amina.
Yeah, thank you so much.
Thank you for your question.
Yeah, thank you.
The next question comes from Baja Quebede de Bela. I'm sorry if I'm not pronouncing it right. What are the socio-economics implications of the results?
Well, that's thank you, Baja, for that question, and that's a big one. These are very huge, of course, and let me start with one of the things I addressed in my talk. It's antimicrobial resistance and mistreatment, and the health implications of mistreatment. If we mistreat women are, and we introduce, well, that's very black and white how I phrase it, but we introduce antimicrobial resistance and we are unable to further treat infections. So that comes, of course, with a huge economic cost. What is also a big cost for the health system is the neonates that are born too soon, or the neonatal deaths that are sometimes easily preventable by just having a good screening. So if we keep on using that syndromic approach, we know that we will mistreat, we know that we will miss a lot of asymptomatic cases, and we know that comes with consequences of neonatal and child mortality and morbidity.
Thank you for that.
Well, I can go on, Baja. Maybe we should do that after that because there are many other aspects also to your question. but maybe for the sake of time, let's take some other questions.
Get down if you want to put on your microphone and your video.
Okay, I see another question of Fitsum. What were your feasibility criteria for the participants in the study? So in an exclusion criteria, indeed, I did not address that for the sake of time, but we only enroll women in their first antenatal care visit. Women who took or who were on antibiotics a few weeks before their visit were excluded, because then we would not have a clear view on the true vaginal microbiome. So antibiotic use was an exclusion factor. And then age, of course, younger women than 18 years old were not included for feasibility reasons, because then we need to have parental informed consenting also.
Let's first go to the question of Getaun, who's here.
Oh, sorry.
No worries.
Thank you so much for the nice presentation. I would like to ask, you mentioned on the presentation, in your presentation, that there is a link or there is an association between gastrointestinal microbiome with the vaginal microbiome. Indeed, it might affect in a positive way the niche, the microbial niche in the vaginal, but at the same time, when you look at how our women do the hygienic thing, if they go for the toilet and then they might have washed, they might do the hygienic system that could also promote the transfer of rectal microbiome from that area to the vaginal area, and ultimately it could affect the vaginal microbiome niche. And that could also be associated. I mean, you can correct me, or you can also link that one with the urinary tract infection. That could also link with any other vaginal microbiome environmental disturbance. I cannot link these kind of things. Could you just explain those scenarios? Thank you so much.
But what's the exact question you want to hear? I heard your introduction, but what do you want to be explained? I'm sorry, I did not get it.
So I think my voice is really clear, no?
Your voice is clear.
Yeah. Okay. The question was, how do you associate the gastrointestinal microbiome, which transfer from the rectal area to the vaginal, linked with the vaginal microbiome niche situations, and also linked with urinary tract infections, which usually very common in women, that could also be linked with STI.
Yeah. Well, how do we link them? Like, how do we link them microbiologically? In a microbiological way, you mean? Okay. So there's, as explained, there's a clear physical association between those niches. And indeed, what you say, that urinary tract infections, they are associated with what's happening in the gut microbiome. But in the gut microbiome, for instance, there are many different E. coli types, but then only few of them are able to colonize the vagina, and of that, only few of them are able to then colonize further the urinary tract. So there are studies doing whole genome sequencing that clearly show that, and the same is true for other bacterial species. We know that the gut, or at least the rectum, is an important reservoir for many of the species that we meet in the vagina, and then from there in the urinary tract. I hope that addresses your question.
Yeah, somehow, but I want to also link the BV with the any kind of bacteria which comes from the if you
Yeah. For BV, I don't think the more important factors are the disturbing factors like sexual intercourse, menses, the use of intravaginal washing. Those are more important factors than the gut, because once you have a vagina colonized by Lactobacillus crispatus, and from a microbial point of view, you don't disturb it, it's quite stable. Even though there's the niche around the corner, let's say, of the rectal microbiome, that lactobacillus is good in keeping the colonization. It's only when you actively try to disturb it, like with showering, sexual intercourse, and so on, that you have risk for a dysbiosis.
Thank you.
Okay, let's thank you for the interesting discussion. Let's get on to the next question from Hannah. She asks if during the delivery, the microorganisms present in the birth canal can be a risk for neonatal sepsis. Is it in those cases that it is diagnosed an option to use a C-section to reduce these bacteria or this risk?
And I don't. This is a big decision to do a C-section to reduce the risk. I don't think this is at this point or at this moment where we still can treat those bacteria justified, because the main bacterium causing neonatal sepsis is still GBS, and it's easily treatable with antibiotics. So that would be the preferred option rather than doing a C-section. Because also, especially in resource poor settings, C-sections come also with a risk of infection and so on. So I don't think this is a good option at the moment.
Okay. Then
Thank you, Hannah, for your question.
Amina asks if people with who are infected by chlamydia, if also their partners get treatment.
In general, if there's an STI present and man or woman, the partners are treated. Even for BV, which is not a true sexually transmitted infections, there are now studies that show that also men should get treated. Although men don't have something like bacterial vaginosis or the male counterpart, it doesn't exist in men. Men should receive treatment, but there's a lot of debate on that. But if your question was for the study itself, it was not done because we only received samples here and did molecular analysis months or even years after the sample was taken. So for our study itself, partners were likely not treated, but they were contacted. Yeah.
Okay, thank you. I'm going through them because the questions keeps on coming. The next question is by Elizabeth. What is the cost implication of the point of care diagnosis used in the study compared to the syndrome management that is in place now?
Well, that's a very good question. We did not do an economical or feasibility or implementation feasibility analysis. Our goal was to come up with a tool, of course, keeping in mind the cost that is really cheap. So it would be considered for point of care testing or for antenatal care screening. That's why we chose those two different techniques that are come with a cost of less than €1 per test. So I cannot tell you much about the cost implementation, but I do know, of course, when we would use our tests or a similar test in those settings, it would come with a higher upfront cost per visit. Namely, we need to do the diagnostic testing. But it would also be cost saving at the program level. So we will limit antimicrobial resistant related costs. We will increase the correct treatment. We will have fewer repeated visits and referrals. We will have fewer neonatal child morbidity, mortality, and so on. But for patient per visit, it would increase the cost. But I'm sure if we take everything into consideration, it will reduce the total costs.
Okay, thank you. The time is running out, but we still have 2 questions. So let's get to the question of Akewok. How does the pregnant person's gut microbiome influences the vaginal ecology and it's a question with a lot of difficult words, susceptibility to
I get
STI,
it.
BV, and what about diet modulate risk?
Yeah. So as explained, the gut microbiome or the rectal microbiome is a reservoir for some bacteria that if those bacteria are present in the vagina, they can be transmitted to the neonate. So for women themselves, they are not at risk, like GBS. If you carry GBS, you don't have any problems. You don't have any itching or discharge. But in pregnancy, when it gets transmitted to the neonate, then it comes with a high risk. And we know that GBS or E. coli or those Klebsiellas, they originate from the gut. So in that aspect, the gut microbiome influences susceptibility for those pathogens. I also see your question about the diet. I know there's an important link between diet and the gut microbiome, but how diet would influence the vaginal microbiome, I don't think there have been any studies on that. I'm not sure if there would be a link.
Okay, thank you. And then the last question comes from Elise. Can intervention on vaginal microbiota protect from infections?
Thank you, Elise. That's a very relevant question, and probiotics and so on have been there for decades. And historically, people have trying to use lactobacilli to restore the normal lactobacillus-dominated vaginal microbiome, but very unsuccessfully. And the main reason, I think, was the use of strains that are normally not present in the vagina. But now there was a recent study who used as a probiotic some very good Lactobacillus crispatus strains, and they combined a few, so they make the mixture of lactobacilli, and it appears to be effective as treatment for BV. Now we need to be very careful in that. It's only one study. But then, of course, if you have a restored healthy vaginal microbiome, you can continue the rationale that will also protect from other infections. I see in your question also transplantation. Well, that's something very exotic, but it has been tested that if you have women who have a disturbed vaginal microbiome and they are unable to restore to the normal status, that they get what we call the microbial transplant. So what is being done is that a donor, a woman with a healthy vaginal microbiome, donates her vaginal microbiome. So they take a few swabs, they make a suspension, and then they spray it in a woman with a disturbed microbiome. And that appears to be, it's very exotic, but it also appears to be a way to restore a vaginal microbiome.
Okay. Thanks a lot for all the interesting questions, everybody. Also, thanks a lot to Professor Piet for first the presentation that was really clear and all the answers that I think were really nice and interesting. So I'm really happy with the community talk, and let's wrap it up here. Have a nice afternoon, everybody.
Okay, thank you. And always you may reach out if you have any further questions. You have my name, so don't be shy. And thank you for the invitation again.